what I'd like to do is as Doug said, I want to talk. I understand that a couple of vendors have been here in the past, and they're major players in all this, and they've demonstrated and showed you sort of how EPA is working. I want to give you a really broad overview of how it's evolving, where things are, what the barriers are, and I'm going to look at it from both the pharmacy as well as the medical standpoint. So when I look at prior authorization, I really look at it in kind of three different buckets: drugs, devices, and procedures. It could be, we could break it up even more if we wanted to, of course. There's services, those kinds of things. But really, for this audience understands why I do it this way, because within health plans, they usually manage drugs in one group and medical in another. And so that's the way I kind of look at it. That's where the rules engines are within payer organizations. And one of the mistakes, in my opinion, that's been made around electronic prior authorization is trying to group it all together as one big conglomerate. In 2004, we said, let's work on pharmacy a little differently, and we've made a lot more progress on the pharmacy side than we are on the medical side. And I'm going to tell you about that and why as we go further. This is a timeline. So what I'm going to talk about now is the pharmacy side. And this is a kind of a timeline of how the pharmacy side has evolved. I always have to begin with any presentation on EPA and a timeline back with HIPAA, because HIPAA named the 278 as the standard for EPA. I talked about the MMA passing in 2003 and our standard development organization that I led until last year, starting in 2004. We had these pilots in 2006. A report went to Congress in 2007. And the most important thing that went into the report was that prior authorization, electronic prior authorization will work, but it would work optimally if we didn't use the HIPAA name standard, which is the X12278. So moving forward, this expert panel was formed in 2008. And what we did is we put together a roadmap for how we're going to move pharmacy EPA forward. And we convened an expert panel. And then in 2011, CVS Caremark did a pilot. We created a new standard on the pharmacy side in 2013. So on the pharmacy side of EPA, we're using the script, NCPDP script standard, something that's different from the HIPAA name standard. And that's, the basis of the progress that we've made so far. Since we're talking about pharmacy EPA, I really need to back up a half a step and talk about electronic prescribing and how electronic prescribing works. And you'll see why that relates to electronic prior authorization in a second here. But what I want to start with is, in the electronic prescribing process, the very first thing that happens is the health plans and the PBMs take information out of their EDI claim systems, and they put that information into a flat file, a standardized flat file, which goes to an intermediary, Schueth, who aggregates this information and then pushes this out to the EHRs. And so then the night before a patient comes to visit their doctor, what happens is that EHR sends an eligibility request to Schueth, who figures out who's covering that patient. And in the response back, what they get are certain data elements that allow the EHR to connect the patient to the appropriate formulary. Okay, so these EHRs have these, drug formularies, formulary databases, and whatnot that exist. This informs that formulary. I call it eligibility informed formulary, and that then leads to the new RX. There are some problems with that process. The biggest problem with that process is that information, and to this audience, I don't need to explain this, but there's always someone, so I always kind of go to the, try to explain what I mean by this. But this information is at the plan or the group level rather than at the individual patient level. And so the way I like to, describe that is I'll use General Motors. So General Motors is the plan level. Salaried employees in Toledo is the group level. And then John Smith or Jane Doe would be the individual patient level. That's one of the challenges that we have with this eligibility informed formulary. Another one that we have is that these fields are not mandatory. So some people fill in the fields and leave others out. We're pretty good as an industry about filling in the formulary field, but here's how we get back to prior auth. One of the fields that we're not so good at as an industry is filling in the PA flag. In fact, in 2016, we did a study, actually from 14 to 16, we did some studies where we analyzed the formularies in the marketplace. And what we saw was an improvement in terms of number of formularies that contained a PA flag, but we were still at only 30%. So what that means is that probably, since almost every formulary has PA, probably about 70% of the formularies that are being provided, through that eligibility informed process doesn't contain a PA flag. That's a problem for prior authorization on the pharmacy side. And when people ask, why isn't it more well adopted on the pharmacy side? That's really, case in point, problem, the biggest problem that we're having. There are a few other problems as well with this eligibility informed formulary, but in the interest of time, I'm just going to make the key point, and that is that physicians really don't trust eligibility informed formulary today. They're not confident that it's accurate. And it's not that it's inaccurate per se, it's that it's a snapshot in time. There's a plan level, potentially a plan level issue, plan group versus individual patient level, or it's missing fields. So the industry gets this. And one of the things that we've done in response to that is we've created a process where we don't have to know prior authorization up front. That's called retrospective. That's on the right-hand side. So the way that works really quickly is the doctor doesn't know that prior authorization is required. They send the prescription electronic to the pharmacy. The pharmacy submits the claim. The response comes back and it's rejected because prior authorization is required. Then that kicks off a whole prior authorization process that's a little bit outside the workflow. And that's why it's not well adopted, but it is, much, much better adopted than we are on the medical prior auth side. Now, what we were working toward and what we piloted in 2006 and where we want to get is prospective PA. But in order to do prospective PA, the doctor has to know the prior authorization is required. So again, a problem that we know we have and we're working on. So the point I would make here is that most of it, the volume that we have on prior auth is retrospective. So the solution that we've come up with is called real-time benefit check. And what real-time benefit check is, it's that sort of automated real-time patient-specific information that's provided at the point of prescribing. This is being piloted by a number of payers out there. Those that have been the most vocal about it and presented publicly include United Healthcare and Humana, but several others are out there, pilot testing this. And it's being used for a number of different reasons. One is we can get patient-level formulary information at the point of prescribing. We also address the missing PA flag. There's a few other things, for example, out-of-pocket cost and those kinds of things that can be better calculated when you know who the patient is, when you know what the drug is, and when you know what the point of dispensing is. But this is an exciting and game-changing new solution that we brought to the marketplace. Just a little more detail about this. We get preferred level, we get age and quantity limits, there's step therapy, we get the channel options. So especially in the specialty world, so a lot of pharmacy now revolves around specialty medications. If a plan has a preferred network, we can identify which pharmacy is part of that network. Again, we have copay, cost sharing details, and formulary level. So what we have right now is still eligibility. We still do that eligibility request. On the left-hand side, that's the initial process I described, eligibility informed formulary, which leads to PA. On the right-hand side, we still do that eligibility, which leads to a real-time benefit check, which leads to EPA, should they choose a drug that requires prior auth. In that real-time benefit check, though, they also get alternatives, and some of the alternatives may not require prior auth. So the drivers right now for prior authorization on the pharmacy side are many, and I probably don't have the time to get into this in a great amount of detail. I would suggest that the number of specialty medications and the cost the cost of the specialty or the drug benefit because of specialty is a big driver of cost savings. We're also working on speed to therapy, trying to get the medication and the therapy to the patient faster. But a couple of federal drivers include prior authorization, the Support for Patients and Communities Act, also known as HR 6, which passed last year, and called for electronic prior authorization for Part D drugs and a real-time benefit check. And both of these are progressing. There have been NPRMs, there's responses to those. The real-time benefit check has gone to the OMB for scoring. We don't know when these will come out, but we expect them to come out yet this year. And we think this is going to have a profound impact, because if you got to do, prior auth or EPA for drugs under the, for Part D drugs, and if you got to do, if the MAPD or MAPDPs and PDPs want to have to do the real-time pharmacy benefit check, we might as well do this for everything commercial as well. So we think this is going to be a substantial driver on the pharmacy side. And the good news is the infrastructure is there. There are still some barriers, but we're working through them. And we think, electronic prior authorization on the pharmacy side is, poised to really take off, kind of like electronic prescribing did in 2008. So what I'm going to do now is I'm going to shift gears a little bit from pharmacy to medical, okay? And so again, this is where I kind of lump devices and procedures together, could also be services. But this is, this is a different world of electronic prior authorization, as most people in the room understand. Some of the drivers are the same. We're also concerned about specialty on the medical side, because in fact, many specialty drugs are covered under the medical benefit. The shift to value-based care is a driver of medical prior auth. Some of the technologies are maturing on the EPA side, and that's another driver. So we're poised, to really move things forward on the medical side as well. But if we go to the next slide, you'll see that we're probably not in as good a spot. If you look at the graph there on the right-hand side, we only have, according to CAQH, we only have about 12% adoption of medical PA, and 51% are being done manually, 36% are being done partially electronic, and by partially electronic, we think, CAQH really means using portals. So this 12% is being done electronic. It's using mostly the X12278 that I mentioned earlier. Companies like Availity is really at the forefront of this. There are others that are out there that are doing medical EPA, but it hasn't been adopted as widely across the country as pharmacy has. But again, it's poised, for adoption, but there are many more barriers that we have on the medical side. On the positive side, on the driver side, the movement toward value-based care, we believe, is a big driver for medical prior auth. There's more of a focus, of course, on patient outcomes. There's going to be increased risk-based contracting. We're going to treat the entire patient and do care coordination. That is really driving medical prior auth. We're going to have to figure out a way to make sure that we get the right, right devices, procedures, services for the right patients at the right time. But there's also on the state side, there are also some laws that not everybody knows about. We do track this, Point of Care Partners does, and one of the things that we found is there are 4 states that will mandate or going to mandate prior auth. I need to make it clear on this slide. It doesn't mean that as of April 12, 2019, it's mandated. It means that laws have passed and they're in the future, but a lot of things like 1120, where prior authorization will be mandated on the state side. I mentioned HR 6, which is driving prior authorization on the pharmacy side. We also think that it's going to drive and have an impact on prior authorization on the medical side. And I'll tell you that, and I've talked to folks at the Trump administration, and I'll tell you that the Trump administration has a priority on reducing provider burden. So, they've really laid out 3 different priorities. One of them is reducing prior provider burden, and they really feel that prior authorization is one of the ways that they can have an impact in this area. So they're very much behind progress on the medical side and wanting to understand what the problems are. There's a lot of activity going on in the industry. So this is this is both two things. It's a driver, but it's also, a trend. It's an indication. It's it's a data point. There's a lot of things that are going on in the industry right now that will drive electronic prior authorization on the medical side. And some of those that are noteworthy, and the ones that are in red are based in a different standard development organization called HL7. HL7 is the standard development organization that's really used by all the electronic health records in the country. And they have a number of activities that are going on right now that will boost adoption of electronic or medical prior authorization. Also, the AMA, the American Medical Association, has been very vocal in their advocacy around prior authorization. They're interested in, of course, well, at the end of the day, if you ask physicians, most of them will say they don't like prior authorization at all. Let's be honest, okay? But the AMA understands that prior authorization is not going to go away, and there are times that it's going to be needed. And what they'd like to do is they'd like to see prior authorization, be electronic. Let's reduce the burden on the physician. And so they've been really, vocal and at the forefront of getting prior authorization, electronic prior authorization out there. Not, of course, ignoring their, what they really like is a reduction in prior authorization altogether. AMA has partnered with several other organizations, including AHIP, and come out with some principles. Those principles are being, considered and are really, really wisely, put together and thought out, and they're really having an impact on the industry. A lot of stuff going on. And in this particular grid, we kind of have our view of what's going to make the most impact. And we think this AMA advocacy and some of the things that are being done in HL7 are going to have the most impact on medical prior auth, electronic medical prior auth. But there are still some barriers. There are definitely some barriers. And we think one of the barriers to medical prior authorization is the X12 278. The problem with the 278 is the 278 was created to be a back-end sort of billing transaction. And what it really is, so it's really outside the workflow. And it doesn't accommodate clinical information that's required really for prior authorization. And so, what we, have discussed, when we've given testimony in Washington, what we really think is that there needs to be either things that, standardized ways to support the 278, which is just a prior authorization transaction, by the way. If you look back to the pharmacy side, it's not completely reflective of what we're doing on the pharmacy side, which is first indicating the prior authorization is required, then facilitating the back and forth, communication, the request response, and maybe additional request response. It's not doing that. It's just sort of a one-time back and forth. So what we need to do, and what those that, where we have the 12% adoption, what those that have implemented it have done is they've supported it with other, communication methods to get information back and forth. So we're doing that though, kind of ad hoc. I've heard, of situations where they, IM to fill in information, they make phone calls, there's faxing, all, kind of on top of that 278. So we think the 278 has been a bit of a barrier. On the pharmacy side, we got away from it. We're not using it. On the medical side, we haven't been able to get away from it. We haven't had an alternative. We think that's one of the things that we're moving toward is not, maybe an alternative or maybe support for it. And I'm going to get into that a little bit more when I talk a little bit more about Da Vinci. So the 278 has been a barrier. The workflow assumption of back office versus front office has been a barrier, and also the trust factor is a barrier. Payers, insurance companies want to be able to audit and ensure adherence to rules. And there needs to be a clear understanding of the data provenance so that they're getting this information, they're trusting that they get this information, from the provider. And so, those have been some of the barriers so far, and we're working through those. I view the world, I always look at all of this through the adoption curve that became popular in the 1990s with the book Crossing the Chasm. So the idea behind that book, and it wasn't looking at healthcare, was looking broadly at technology. But the idea behind that was that there were innovators, early adopters, early majority, late majority, and laggard. And the innovators, they're the ones that think this is a really good idea, so we're going to try this, and we're going to make it happen, and because that's our culture and that's what we do. Then those early adopters, they're a little bit less sort of risky, but they give it a try. They push things forward, and there's kind of a chasm that exists with those early adopters. And if you can get past that chasm, then what you see is widespread adoption in the marketplace. Where I would suggest that we are is we're past that chasm on the pharmacy side. We still have a couple of barriers that I talked about, but we're past it. On the medical side, I think we're kind of still with the innovators and early adopters. I think we're still working through how we're going to do this. Um, and if you really break it down into different kind of stakeholders in EPA, I can talk about some that are more innovative than others. I mentioned United Healthcare and Humana, which have publicly, talked about their RTBC, real-time benefit check, going back to the pharmacy side. They've also been pretty progressive when it comes to prior authorization on the medical side. Some EHRs have been more so than others. Um, uh, Allscripts is an example of a company that has really been trying to figure out, how do I do electronic medical prior authorization better? I mentioned Availity, so there are some companies that are really pushing this forward. And I think kind of where we are on the medical side is we're right kind of there at that chasm. So I've kind of alluded to this, teased a little bit with this Da Vinci project. I want to talk a little bit more about it because I think it's super exciting. I think it's game changing. And, full disclosure, we are the program management organization for Da Vinci. So I'm not, a lot of times when I'm talking about these things, I'm talking very neutrally, with a broad view of the industry. In this particular case, we are right at the precipice, right at the center of this, making it happen. So I'm not completely neutral on this. I'm a part of it, but I feel really good about this, and I really do believe it's game changing. What happened was a couple of years ago, at the time it was 12, it's now grown to 14 different payers came together and said, we need to address a challenge that we have in the industry called, that I talked about earlier, of value-based care. We need to figure out how we're going to support and value-based care. And really the only way these folks that came together decided that the only way that they were going to do that is if they could communicate and get information into and out of the electronic health record. And so, but they wanted to do that, not in a vacuum. They didn't want to build, proprietary solutions. They wanted to build something that's open source that everybody can use. And so these organizations started looking at what was going on in the industry. And what they saw is there's a project called the Argonaut Project, which is leveraging FHIR, F-H-I-R, in support of exchanging and interoperability and exchanging information, between electronic health records and providers and the provider side. And, they said, hey, can we be a part of that? And then, Argonaut said, well, look, we're really focused on kind of our use cases. Maybe you guys should start one of your own. And so they said, good idea. And so they went off and they did it. And so the idea here is to accelerate standards development in support of value-based care. And so they chose to do this through HL7 because, again, as I mentioned earlier, a lot of the electronic health records, EHRs, are built on HL7 standards. So they chose to do this through HL7. They formed a payer group, a group of payers, EHRs like right now involved in it are Epic, Cerner, Allscripts, and Athena. They have 10 different, health IT vendors. They have provider organizations such as Rush in Chicago. They have, and what they identified initially was 9. It's up to now 14 different use cases that support value-based care. And obviously, some of them get into EPA, and that's what I'm going to get into at the next slide. Okay, so here are kind of the 9 initial use cases that they identified. And we've kind of organized them in sort of buckets. So the first bucket is quality metric collection. The second bucket is clinical data exchange. And the third bucket they're calling pre-order burden reduction, also known as a medical prior authorization, electronic medical prior authorization. I'm a little tongue in cheek, but it really is kind of the basis of that third bucket, that third row is kind of the basis of electronic medical prior auth. They didn't just call it that because they really want to be, wanted to be able to support other use cases and a broader set of burdens that are out there in the market. But that's that bucket. Okay, so the coverage requirements discovery basically said, is there an authorization required? And are there predecessor tasks that need to be completed? So, I started with pharmacy because we've made a little more progress on pharmacy. I mentioned the RTBC, real-time benefit check. In some ways, this coverage requirements discovery is like that real-time benefit check. It's saying, is prior authorization required? And today, often, providers don't know if it is or isn't. If it's a procedure that they, do a lot, or if it's a device that they order a lot, maybe they do, but sometimes they don't. And so this is, sort of clarification that prior authorization is required. The second use case is documentation templates and coverage rules. So if there are prior authorization tasks, then show me what I'm missing. Show me the criteria rules so that I can evaluate treatment options, locations, next steps. Okay, so if I can't do it here, where should I do it, or where can I do it? Give me that information so that I can manage my patients. And then the third bucket is authorization support. So if authorization is required, then either send me to the place to complete it, or better yet, queue it for staff that that they can proceed with this. And this gets to that trust that we mentioned earlier, where we're going to be able to address one of the trust factors. So this Da Vinci effort involving all of these different payers. Oh, and the payers, I didn't mention who specifically they were. So it is United Healthcare, it's CMS, it's Blue Cross Blue Shield Association, Cambia, Anthem, a number of different organizations that have and Rush that have stepped forward and said, this is how we're gonna be able to push this forward. They've contributed money to HL7 to make it happen. Consultants are out there writing the requirements for these use cases, the implementation guides, and doing reference implementation. All this is going to be open source, available to anybody to be able to implement. And that's what it's all about, is creating an environment where we can support value-based care. So kind of the way this looks a little bit is, that Da Vinci authorization support that I mentioned earlier will then, lead to the 278 and the 275, the transaction where information is exchanged for medical prior auth. The 278, again, is the HIPAA name standard. The 275 is a wrapper. So what it wraps around, or what it does, is it allows us to be able to do an attachment. It could be a CDA. It could be, heaven forbid, we want to automate all this, but it could be a PDF. But it allows us to be able to attach clinical information and include that with the prior authorization request. So more broadly, for those of you that are technical, here's how, all that expands. On the top, we're able to do a coverage requirements discovery. On the, on the left-hand side, the provider executes it. It goes to the right-hand side. You get a response back that prior authorization is required. You do the documentation templates. So you say, okay, if it is, what do I have to do? We have the support and the 278 and the 275. There's another sort of term that I've introduced here that you may or may not be familiar with, and that's called CDS hooks. That's another sort of standardized method of leveraging decision support in the electronic health record to be able to support different kinds of clinical decisions. But the thinking is that we could leverage CDS hooks for medical prior authorization as well. And ultimately what this does is it improves transparency. It reduces the needs for authorization if they have that information, when they find prior authorization is required. So in some cases, you don't have to proceed with a prior auth, and also leverages available clinical content and increases automation. So, what I want to do now is kind of leave you with a view of our view of where the future is headed, and then we're going to open it up for questions. So, with sort of, I've got like sort of 5 things that we just did a report on electronic prior authorization, just came out as of yesterday. And we identified these sort of 5 things in that report. And this is our kind of prediction for where things are going. For one thing, we really think that Da Vinci is really important to to medical prior auth, to sort of addressing some of the deficiencies we have. And you know what? It's not only us that thinks it, so does CMS, so does ONC. ONC has a group, the Office of the National Coordinator for Health IT has a group that's working on creating the infrastructure to support medical prior auth and narrowly and more broadly value-based care. And CMS has been very active in the Da Vinci project, and they're going to want to pilot this later this year, and we expect that to happen this year. Back to the pharmacy side, we think that RTBC is going to make a profound and game-changing impact on prior authorization on the pharmacy side. Again, the missing link is that prior authorization flag. Now, I had a lady at NCPDP, earlier this week, speak about it, and she, made the key point that prior authorization flag and the RTBC, it's going to take us a while to get that out there in the market. So one of the things that we need to have happen is, payers and health plans need to be more diligent about populating the PA flag and the formulary and benefit. We still think there's going to be a need for both formulary and benefit as well as RTBC, but we think RTBC is game changing. We think prospective prior authorization is the way to go on the pharmacy side. We think that the CDS hooks that I just mentioned is going to be game changing on the medical side in terms of, pulling out information that supports medical prior authorization, so the doctors don't have to rekey all this information, or their staff, don't have to rekey all this information. So we think CDS hook is going to be profoundly impactful. We think that FHIR and HL7 and the Da Vinci use cases are broadly going to be impactful. And then we also believe that within the next 2 years, a number of microsystems of payers and providers are going to be able to enable blockchain-based platforms of truth to move forward. Now, I didn't have time to really get into blockchain, which is kind of a whole nother discussion, but that's another area that we go into in our report, and we think is going to have a profound impact in the next couple of years. So we think it's an exciting time for electronic prior authorization on both the medical and pharmacy side. We think we're poised for things to take off. I mentioned electronic prescribing. I was involved in electronic prescribing. I like to use that as an example and say, like it did in 2008, we think we're on the precipice of that kind of increase in volume. On the medical side, we have a little more work to do than we have on the pharmacy side. But that's sort of where we are today.